Welcome to Talking Meds on the PrescQIPP podcast, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill. Hello and welcome to the latest episode of Talking Meds. I'm Jonathan Underhill, your host, and I'm joined again today by Sundus Jawad for the next in the series of our podcasts, Caring About Medicines and Care Homes with Jonathan and Sundus. You'll remember Sundus has over 25 years of experience as a medicines optimization pharmacist, working closely with GP practices, care homes and other providers. She manages a small team of pharmacy professionals responsible for medicines optimization in social care and care homes in Frimley. Sundus, hello. What are we going to talk about today?
Hi, Jonathan. Yeah, I thought today we could talk about the power of networking and how we learn through networking.
Brilliant. We talked about the importance of networks previously, haven't we? I'm a huge fan of the importance of networks, not just for staying in touch with people, but also importantly for what's called diffusion of innovation. So Trish Greenhoff, who's a professor of general practice, did a systematic review back in 2004, actually, about how do we get good ideas spread across the NHS. It was other service organisations as well. And she talks explicitly about the importance of having good networks within that. So why are networks important to you, Sundus?
Well, as I said, it's really important because particularly with care home work, I think I've said this previously, that care home pharmacy professionals, particularly pharmacists in the early years, we were working very, very much in silo, and we didn't really have anyone that we could go to for a second opinion, or can I sound you out on something? I've got this really interesting patient or a really interesting scenario or issue. So the power of networking just helps you to, number one, find others like you in other parts of the country. They may have already experienced the issue or the problem that you're facing, and you could get second opinion, maybe even support, maybe even a resource that they've already developed for the issue. And I kind of learned this really early on, the power of networking, and through various networks. So the one I suppose that I found most helpful is probably the PrescQIPP virtual professional group. That's been running for well over 10 years. And I think we've got over 400 members now on that group. And PrescQIPP were really, I think, really quite ahead of everybody else, in terms of their thinking around care home pharmacy professionals networking. And I remember really early on in my career where we had, the likes of Nina Barnett and her, kind of added experience, really, really experienced professional. She really gave us a lot to think about. And I remember going away after every meeting thinking, wow, that's, I've learned so much here. Lely as well, over the years, she's been incredible on that group. And, Jackie Smith, who, if people remember her, she did this, Jackie's one I'll never forget, because she did some fantastic work on something so simple, which was just training care home staff on how to use inhalers correctly, just checking that they understood the inhaler technique. And, that had a huge impact on her care home patients. So I remember her sharing that. I think that must have been about 10 years ago now. And yeah, it's just, those kind of networks where we're sharing, learning from each other. Number one, it makes you feel like you're part of a community, but also that there are others like you who are also doing either similar work or they're ahead maybe, and they're able to share some really important golden nuggets, which you take away and then, try and implement yourself.
Yeah, I mean, I've certainly benefited from the networks that I've built up over the years, and having something like a virtual professional group where it's easy to get in touch with people and to make contacts and to make friends, etc. And asking, well, I've got this patient, I've got this case. I'm not quite sure. What would you do? And you can ask individuals like I would always, when she was still with us, would go to Nina on it and say to her, Nina, what do you think about this? And her wisdom was excellent. Lely as well, you mentioned, great. But there's the wisdom of the crowd here as well. And you just ask in a virtual group, and you outline what the case is and what the issue is, what the challenge is, and the group often has some really good suggestions for what you might want to do next. I mentioned Trish Greenhalgh's systematic review earlier. One of the things she talks about within that is the difference between being a blue tit and being a robin. Now, I love robins. I love to see a robin in my garden, but you only ever see one robin, don't you? Because they're territorial and they don't like talking to other robins. Whereas blue tits all flock together and they all talk to each other. And there's actually some evidence to suggest that blue tits are really, really good at problem solving. Things like getting milk out of a milk bottle when we used to have milk bottles delivered on our doorsteps. Blue tits would peck through the foil of the milk and be able to drink the milk. And apparently that's because they used to communicate with each other about how that happened. Whereas I don't think robins are as good as that. So be a blue tit rather than a robin in your networks. That was the message from Trish's systematic review. And the other thing in that, and I think you get this with any virtual professional network actually, is the idea of having boundary spanners. Now, this isn't a tool that you use to tighten a nut or anything. It's people who have foots in different camps. So you might have somebody within the group who works part-time in a community pharmacy, for example, or works in a hospital setting. And because they span different boundaries across care, they can take that learning from one to the other. And having good boundary spanners within your network is really, really important as well. So the virtual professional network, the PrescQIPP one, yeah, as you say, 420 members. We'll put a link in the show notes so people can join that if they want to. Meet quarterly. We normally get about between 70 and 100 people per meeting. So there's lots of important stuff in there. Now, Sundus, when we were talking earlier, you mentioned there was a couple of cases that you've come across in your career where the network has helped you have a different view about how to approach how you'd look after people, didn't you? Do you want to just give us a couple of examples?
Yeah, so all of this networking and learning over the years, one of the most important lessons I think I've taken away from others, so this is my learning, is that actually, it's really, really good to sometimes just take your time. We've just got to remind ourselves that these are really complex patients, and they're in a new environment in some cases. So take your time. Don't rush through. You might think, oh gosh, I can see this needs to be deprescribed, or this is missing, or gosh, there's been no blood. But sometimes it's just worth just taking your time. Sometimes you need to just watch and wait. And sometimes you need to give others time as well. So that was one of my kind of really, what I've learned over the years through the networking from Nina, and all of her incredible golden nuggets over the years that she shared. Lely as well, Jackie, Charisse, all those people that we've seen on the VPG over the years. So one case, I suppose, or patient, and I'll try and make it, so it's not identifiable. But yeah, one of the patients that I had was a really elderly lady. I think she was in her early 90s, had lived independently till that time, and now had moderate to severe dementia and was in a care home because she's no longer able to look after herself. And she'd actually lost her some of her language. So she could still speak in French, which was a language she taught as a French teacher, but she couldn't speak her original language and English. So I think she could speak a number of languages, but French was the only one that she could now converse in. She was obviously quite fond of languages. And what had happened, so she was new to the care home, and the care home wanted me to, they said, oh, could you do a review on this lady? She's had a fall and we think it's something to do with her medicine. So I said, yeah, that's fine. And when I looked, I'd kind of realised, I thought, gosh, there's quite a lot of, huge number of medicines here. When I looked at her history, very, very, not had a review in many years, in fact. And then what I'd realised through the review with her daughter was that her mother, that the patient, the resident who I'd been reviewing, had actually not been taking her medicines when she was living alone. And then all of a sudden, she's new to this care home, and all these lovely people, care staff and nurses, now administering her medicines, religiously. And so she was now taking all of these medicines all of a sudden, and she'd had a fall because of the impact of all of these medicines now being administered. And she'd not been taking them for all of these years, and people had just assumed that she had. So they were quite worried, and I think that was the real cause of the fall. A huge drop in blood pressure. When we checked her blood pressure was really low. So I said to them, it's probably all of these medicines. We do need to think about, reviewing to stop some of these. And when I spoke to the daughter, she was quite frank with me. She said, it's interesting what you've said, because my mum has never taken medicines. The only thing that she has ever taken is paracetamol. And she always used to say, if I ever get old, please remember, I don't like medicines. I only ever want paracetamol because it gets rid of the pain. I don't want any fancy medicines. And this is what her daughter was saying. I don't want to take any medicines when I get older. And the daughter said, I would be really grateful if you could just stop all of these, which was quite, we normally don't get that kind of a reaction from family. Normally they're kind of, really anxious, and why are you stopping? And would that not harm my loved one? So it was quite, even to me, threw me a little bit, like, stop everything. Wow. All at once. That's going to be a bit tricky. So I said to the daughter, why don't we, I understand, thank you for sharing, what your mum's beliefs and what she's told you over the years, and what's important to her. But let's take our time, and you have a think about which ones you think we should leave till last, so we can work through them. And we kind of went through a kind of let's watch and wait, and we started to reduce kind of 2 or 3 medicines at a time. Obviously the ones that reduced her blood pressure first, because that's what had caused the fall. And that was a kind of, and I'd learned that from others like Nina, like Lily, like other pharmacists before me, clinical pharmacists before me. So, and it was something that I'd really wanted to apply. So, take your time. Take your time is kind of the biggest lesson, really. And watch and wait and give others time. So give the family time, because, she might have, I thought maybe the daughter's got emotional here and she's now saying, oh, let's just stop everything. But later she might get quite upset that we've stopped everything. So actually, let's, I had to explain, we can't just stop everything all at once anyway. We'd have to do it gradually. So I said to her, you also have a think about it. Which ones do you think might be more important, even though your mum has expressed there are some really important medicines here. So I gave them time as well to have a think about it, and then we met up a week later and started a kind of gradual reduction of medicines.
Brilliant. What a great story. I think that, again, there's lots in that. It's that, first of all, there may well be less experienced care homes pharmacists or pharmacists listening to this, and you think, oh, I'm not sure about this. Others will have more experience than you, though, and can give you that reassurance that you just got. Sundus, that is actually, no, this is okay to do this. We've done this a lot of times before, and given you that reassurance. The other thing that comes across to me is, and we've talked about this on the podcast before, the use of the mnemonic BRAN. So it comes from the National Childbirth Trust about sharing information for people to make decisions about their how they want to go about their childbirth plan. But we use it in medicines now as well. So BRAN, where you explain the benefits, the risks, the alternatives, And the N stands for what happens if we do nothing. And sometimes we forget about that. And what you've just talked about here is ask the person what matters to them, or ask their carer, if they haven't got capacity, what matters to your mum or your dad. What do they really, really care about? And if that is actually they don't like taking medicines, explain that actually if we do nothing or we don't do any change, then that can be reassuring as well. Importantly, you said, we can't just stop everything overnight if things have been started, because you obviously have to do that gradually. But I do think sometimes people forget about the N in Bran, um, and we focus on maybe wanting to intervene rather than thinking about, well, actually just waiting and seeing with a bit of experience. And it isn't just leaving people, it's actively watching and waiting. It's an intervention in itself, but that can be a really, really useful, beneficial intervention to use. And it's that getting that experience from others who say, well, I've been working in this field for 15 years. I do that routinely. This is how I do it. This is the conversation that I have with people. And that might be something that's worthwhile you exploring as a skill for you to develop as well, because it is a real skill. The importance of that communication and being able to have that consultation in a person-centered way isn't something that comes naturally to people. You learn from watching other people do it. I learned lots from watching Nina having conversations with people. The CPPE shared decision making module is really good. I'll put a link in the show notes to that as well. But there's some great videos of Nina Barnett and Barry Jubraj doing real person-centered communication on this, and it applies to all sectors of care, but also within care homes as well, I think, Sundus. So no, that's really what a great example to start with. Brilliant, and the importance of networks there as well. So, anything else? Any other stories that we can share?
Yeah, well, there's lots of stories, Jonathan. So I can definitely think of a few more. Um, so yeah, and I'm just thinking about the networking and the learning. So I suppose from that particular case study, the learning was really it's okay to wait and watch at the beginning of when you first review someone. When you come back later, you can still wait and watch, because even if you go down the route of deprescribing medicines, you still have to wait and watch what's the impact of that deprescribing, and so on, and right the way through. So it's not an all or nothing thing when we review people's medicines. That watching and waiting is really throughout the time that you're involved in their care and the review of their medicines. And it's a journey. It's not a 30-minute SMR or medication review. The second case study that I think that comes to mind is really one that I will never forget. Unfortunately, the resident's no longer with us, but it was a patient who was in their late 50s and lived in one of our more kind of high needs nursing home, where the majority of residents were severe dementia, so lots of nursing needs. He had actually had an accident and was paralyzed from the neck down, unfortunately. So needed lots of nursing. And what really struck me when I went to visit him, they told me he's the only person you can have a conversation with in the care home. So I thought, oh, I'll do him first. And you can do your medication review directly with him. He's got full capacity, mental capacity. So when I went to visit him, what I noticed after he said, come in, when I knocked on his door, was all of these boxes all around the room, towers in one corner. And I just thought, oh my God, this room, which isn't very big in itself, and with a dressing table, TV, a bed and a wardrobe, I thought, gosh, there are boxes everywhere here. Creams all over the dressing table, things on the windowsill, spray bottles, creams, boxes, catheter boxes, towered high. And then as I kind of, introduced myself, worked through what I was there for and what he was, exploring what he was worried about. He said, oh, and I said to him, gosh, you've got quite a lot of medicine, quite a lot of medication here and other items in your room? Is there a reason why they're all being stored in your room and not in the medication room, which is what we'd normally see in a nursing home? And he said, oh, there's more in my wardrobe. Have a look. And I opened the wardrobe and all these other things fell out. And I just thought, oh my word, I've not seen this before. And I kind of started to, through the conversation, and you're right, this is where the art of consultation skills is so important. I kind of started to sense that he had wanted all of these items in his room so that he could keep an eye on the stock, because he was very, very concerned about specific night bags, running out, specific catheters running out because of a previous bad experience, which he said, meant that he ended up in hospital with an infection. And he said, I never want that to happen again. So he was really, really quite anxious about running out of specific items, wasn't using others, was really frank with me and said, I don't use this, this caused an allergy, but they keep ordering it. So he wanted to keep an eye on the stock, but he had no control over the ordering. And I thought, gosh, we've got waste here. We've got somebody who's a patient expert and knows everything about every single item that's being prescribed for them, but has no control over the ordering. The staff did not seem as knowledgeable about, why, his history around what he'd used, what hadn't worked. And again, from learning from one of our network groups, I remember Nina and Lely, they presented something, it was an SPS event in London, and something about, patient experts and listening to the patient, and really important to find out, what does the patient want? What's important to them? What matters to our patient? And I said to him, well, what, tell me what would matter to you? How can we resolve this issue? And he said, well, I'd like to know when they order things. I want to know what they're going to order, because I don't need half of it, and they're not ordering what I do need. And he was, evidently really frustrated. So I suppose, to cut a really long story short, after multiple visits, what we ended up with was, I'd shared with the care home manager. I said, look, this resident is different to all of the other residents in this nursing home. He doesn't have dementia. He's younger. It's just that he needs specific nursing needs because of him being paralyzed. And he is actually an expert in everything, about him, or everything that's happened to him. He knows everything, what was started, why it was started. They were treating him for some postural type of hypertension. When they lifted him up, it was drugs I'd never heard of. So big learning curve for me, but also for the care home, because I'd gone to them and said, he is an expert, he's what we'd call a patient expert. They said, what's that? So I had to explain to them. So then, this learning is now being shared with the care home staff. And I had to explain to them, what a patient expert is and why he needed to be more involved in his own care. And it kind of concluded with him having a list of everything that he felt he needed and wanted ordering, and the stock quantities being written at the beginning of each. So it's kind of a weekly kind of quantities, I suppose like a running balance really of each item. And then he would decide what needed ordering, and would tell the nurse to order on his behalf, and it would arrive at the care home. So, what matters to the patient, that was something I'd learned, and that I had also shared with care home staff. You need to find out what matters to your patients or your residents. Not all of them are the same. We're in a care home where, yes, 99% of them have got severe dementia, unable to communicate, and we're having to do best interest decisions on their behalf in some cases. But this resident is different. You need to adjust your style and, to meet what matters to him. So that was a really memorable medication review that will stay with me.
Yeah, what a great example. And again, it's that sort of, if you're used to a certain type of person within your care, you default to that setting, don't you? So if you've got lots and lots of people who don't have capacity, if you have somebody admitted who does have capacity, I guess it's quite easy to forget that, and you're just not used to doing that. So really important to ask that question. This reminds me a little bit of the conversation we had with Deb Gompertz about the Show Me Your Medicines pilot that they did there, where you just ask somebody, so tell me about your medicines, show me them, how do you use them? Having that conversation with someone who's got capacity would be really enabling for the care home staff there. If they'd have just said that to this guy, it would have made things a lot easier, I think, for them. And the other initiative that I think of that this reminds me of is Graham Presswitch's work on Me and My Medicines, where it was all about the person. Graham talks about the person being the project manager of their own medicines. And I love the idea of that. If you've got somebody who is, yeah, I care about what happens here because it's me. And there's nobody going to be more motivated to look after your medicines than yourself and the person that you've just mentioned there. So let's not forget that when we're doing medication review. Ask people to show me your medicines, and also if you want to be the project manager of your own medicines, then please be that, and we can then work in a partnership. So no, that's really another great story to share with listeners here, Sundus. Just for the last 5 minutes or so, obviously at the start of July, we had the NHS 10-year plan published, so Fit for the Future, as it's called. I just wonder what your initial, and it's still very early days. We still don't know about the implementation plan, the delivery plan, or anything like that. But just in terms of your initial thoughts about what the implications are, perhaps for care home settings and care home pharmacy professionals within the 10-year plan.
Yeah, it's really, really good question, Jonathan. The NHS is really quite complex,
Yes.
and we keep hearing people say, "Oh, medicines are the most widely used intervention within the NHS." So, yeah, I think from initial thoughts and of what I've read so far of the 10-year plan and what I've heard so far is that it is quite ambitious. I think that's quite ambitious. What the ask is, but really, I think for me, what's probably disappointing in some ways is that if medicines are used in kind of 80% of NHS activity, are we making the most of of pharmacy professionals? I think for me that was that's the takeaway message. I looked. You mentioned care homes. Care homes is only mentioned twice in the plan. Some positives in that 10-year plan, in terms of neighborhood models coming through, care models. And pharmacists or pharmacy professionals have been mentioned, in terms of being important healthcare professionals as part of those neighborhood healthcare teams. But really, we need more detail as to what's going to be expected of these pharmacy professionals. Is it to do kind of proactive structured medication reviews? Is it to support in other ways, such as preventative care, such as vaccination or screening? Or how are pharmacy professionals going to be, made the most of, really, in this new 10-year plan? So I think we really do need more detail on what's expected, and also on the delivery and implementation. And also, what's really disappointing, and I know others have also said this, is that we know we have, 2026 is an important year in the world of pharmacy. All new pharmacy graduates will graduate as independent prescribers. They will be prescribing clinicians, and yet there was no mention of that in the 10-year plan. We will have an entire new generation of prescribing pharmacists who will be able to add so much to the NHS, help so much with pressures, and yet there was no mention of this. So, yeah, it would be good for more detail, I think.
It's an interesting. So my initial response, I'm usually quite a positive person.
Mm.
What I always do with these documents, I do a control F of things like pharmacy. So how many times is pharmacy mentioned in the document? It's mentioned 15 times. And most of those times where it's mentioned, it's prefaced by community pharmacy, which I think is really positive, actually. And if I think about what happened in Northumberland, where the neighbourhood plans and Jim Mackey's sort of blueprint for this, community pharmacy were at the centre of a lot of the neighbourhood care teams. So I think that's a really positive thing. But you're right, there is an untapped potential here, and because I'm quite a positive person, I thought, oh, that's just implicit in what they've written in the plan. They know that there's going to be all these prescribing pharmacists, so they're just taking it for granted, and they're obviously all part of the plan. But I think that does need to be explicit in any implementation plan that goes alongside that. And I'm sure the teams at the DH and NHS England are thinking long and hard about that. The Pathfinder sites around the Pathfinder work around independent prescribing and community pharmacy has been really, really good. The stuff that Anne Joshua and Waz Bakir have done has been fantastic. And we need to maximize that potential as well. I also did a control F on medicines, and medicine is mentioned 71 times within that. Medicines is mentioned 32 times. And genomics is mentioned 119 times. And often when medicine is mentioned, genomic prefaces that. That worries me a little bit because I think, as you said, Sundus, the NHS is a complex organisation. Healthcare is a complex issue. I worry that people think that if we just have genomic coding and we know what people's genes are, we can then find the medicines that are going to work for them according to their genetic code. And that might help a little bit, but I don't think it's going to fix our problems that we have in the NHS. So I do worry a little bit about that. The importance of the fundamentals of care still apply here. You still need to have clinicians who are accessible in those neighbourhood communities, and community pharmacies are really, really good at that. And booking that inverse care law, community pharmacies are where people are situated where people need healthcare the most, actually in those deprived communities. And we talked about that with Adam Todd in a podcast around his work. And the other thing that I think about here as well is there's lots of onus being given to the new NHS app or development of the NHS app and having a digital solution to a lot of this. And I think that's great. I think we do need to harness machine learning and AI in our healthcare, but it's not going to fix the problem because the NHS is complex and you can't fix it. All you can do is improve things a little bit. And I do hesitate when I think about the previous large IT projects in the NHS that have not gone well for the NHS. And I worry that there's too much onus being put on the NHS app being able to fix everything. I think it can help a bit, and I do hope there's proper investment that goes into looking at how we can get an NHS app or an NHS digital solution to a lot of this. But we can't forget about the fundamentals as well. So for me, lots and lots of positive stuff in there. Also stuff that I still think the devil will be in the detail around this, and exactly how this is going to work in operational terms is going to be really interesting.
Yeah, I agree with you. I think, time will tell. For me, the main positives, I mean, like you, I'm usually a very positive person, cup full, if not overflowing. But really, I mean, for me, the positives with this is that frailty is highlighted, and that applies not just to care home patients, but to all our elderly patients. So a mention of frailty, a mention of these neighbourhood healthcare teams, lots of mention of the community. We need to maximize on community care. That's where some of our preventative care can, be implemented. But really what we'd like is to see a kind of clearer plan for how all of our future independent prescribing pharmacists are going to be part of these new neighbourhood healthcare teams, and how we can put their good clinical skills to in terms of proactive care for our ageing population with frailty.
Absolutely, couldn't agree more, Sundus. So let's finish on that positive note, shall we? We're both really, really positive about the future of the NHS. I do think there's lots of good stuff in here. It's just, let's just wait and see exactly what happens with it all. I'm hopeful. I'm always hopeful for the future. Sundus, thanks very much for yet another fantastic conversation. We'll put links in the show notes to the virtual professional group at PrescQIPP. I'll put some links in the show notes to the other things that we mentioned, such as Trish Greenhoff's fantastic systematic review. It's about 300 pages long. I don't suggest you read it all, listeners, but there's some really, really good stuff in there. And we'll see you next time for the next episode of Talking Meds. Thanks, guys.